Reflexes. Now, just before I begin, I think it's important to appreciate that there are in fact a whole range of different types of reflexes, and these perhaps arguably commence from the developing fetus whilst in the womb, but certainly we recognise them in the young newborn, the neonate, as well as the little child while they're a baby. So for example, the startle reflex and the Landau reflexes. But in adult life, we look at superficial reflexes and deep tendon reflexes. The vast majority of reflexes that you will come across in the clinical setting and or context, or will have seen, are your deep tendon reflexes, and that's what this video is about. What we are performing, why we are performing the deep tendon reflex, what we are assessing, what do the findings suggest or indicate, and how do we actually denote this in the medical records. So without further ado, deep tendon reflexes essentially are part of the neurological examination. We perform these on the upper or the lower limbs. We can refer to them as extremities. In the upper extremity, we've got 4 reflexes that we generally assess. Again, I'm referring here to deep tendon reflexes, and the lower we have 2. I'm going to use the lower leg as an example to try and understand what exactly it is that's happening. Important things to note are that in order to actually elicit a deep tendon reflex, it's imperative that the tendon that we are striking with the patellar tendon is actually under tension, except this tension has to be passive. So for example, when we look at the knee, we are about to strike the patellar tendon, which sits between the inferior aspect of the patella and the tibial tuberosity. Superior to the patella, that's the quadriceps tendon, and that essentially comes from the quadriceps muscles. So in order to place the quadriceps muscles and therefore the relative tendon under tension, we have to passively flex the knee. So we will ensure the knee is in flexion and therefore the tendon under tension. Only then it is that we will be able to elicit that reflex. So when we are eliciting now in equal fashion, the other situation is the S1 reflex. So your Achilles tendon, for example. Now appreciate the Achilles tendon comes from, it's a common tendon for both the soleus and the gastroc. So the gastroc being more superficial than the soleus in the posterior compartment of the lower leg. And what we do in that situation is we dorsiflex the ankle, or the foot rather, and therefore place the Achilles tendon under passive tension. Once again, when we strike the actual Achilles tendon, we then get contraction of the soleus and gastrocs, hence eliciting that reflex. So the actual eliciting of the reflex is actually contraction of the muscle, and that's what you're actually looking for. Contraction of the muscle to which the tendon comes from, or from which the tendon comes from. Now, the important thing here is, why do we do these, and when we perform them, what are we exactly assessing? We're actually assessing the integrity of the reflex arc. So what exactly does that mean? Understand that we are assessing myotones, and myotones are essentially the muscles that are innervated by that nerve. So let's look at the knee and therefore the quadriceps muscles. So the actual vertebral level from which the femoral nerve comes out, that then innervates your actual quadriceps muscles, is generally L3-4. The femoral nerve is L2-4, but it's the L3-4 region that largely innervates these quadriceps muscles. And so what you are doing is you're assessing the sensory nerve, the afferent nerve from the quadriceps muscle group rather, that then goes into the spinal cord via the dorsal root ganglion and the dorsal horn. It synapses with the relay neuron inside the actual spinal cord, which then synapses with the efferent neuron, the motor neuron, via the ventral root, the anterior root, and that then goes to innervate the actual quadriceps muscles, and that's your myotome. Look at the S1, for example. Look at the Achilles tendon, for example, the soleus and the gastrocs. Again, efferent neuron goes and it stabs, inserts into the spinal cord from the back. That's your afferent or your sensory neuron, again via the dorsal root ganglion. Dorsal horn into the spinal cord, relays with the synapse of the relay neuron inside the spinal cord, and then exits via the ventral horn from the front, and that's your motor or your efferent neuron, which then goes to innervate the gastrocs and the soleus, and that there is your myotome. So if you kind of conclude that, you've got two separate circuits, two separate reflex arcs, and that's why when we're assessing deep tendon reflexes, we assess these very, very local areas. The same principle is applied when we're assessing dermatomes. So when we're doing sensory testing in the specific dermatomes, we're assessing the same kind of thing, except different tracts, and that goes down the lines of specific tracts and their integrities. Going on to actual then understanding how to interpret the findings. So there is a grading system. As with anything, there is more than one grading system, but the one that's most commonly used grades your reflexes from 0 to 4. 0 referring to absent reflexes, 1 referring to hyporeflexic, 2 referring to normal reflexes, 3 hyperreflexic, and 4 clonus. Now clonus essentially is a situation where you have elicited a hyperreflexia, but then there is continued rhythmic contraction of the actual muscles that are being assessed. Again, depending on what reference you read, any more than 5 or between 5 and 10 is deemed as being clonus, and generally any more than 10 is indicative of some sort of pathology. But the important thing to note here is anything that is above 2 out of 4 on your reflexes generally may indicate an upper motor neuron lesion. And upper motor neuron lesion versus lower motor neuron lesion is a separate video altogether, and that helps you to understand whether the pathology at hand is in the central nervous system or the peripheral nervous system, respectively. Hyperreflexic can be normal, except in very toned patients or for the patient themselves, but clonus generally needs investigating, and it must be investigated. The other thing we will consider noting is we are assessing deep tendon reflexes on the appendicular skeleton, i.e. your limbs upper and lower. And the beauty here is that we will then be able to compare left from right. And so it is imperative when we do deep tendon reflexes, we do them on both sides for comparison. So when we then denote this, we will say, let's say for example, deep tendon reflexes measured 2 out of 4, all present and equal. Because you've got 4 on the upper extremity, you will assess all 4. In the lower, you've got 2. So are they all present and are they all equal? And the final thing we can note here is if the patient is concentrating because they are, say, for example, apprehensive or otherwise, in view of the fact that you're about to strike them with a tendon hammer, what you've got to consider is they may be concentrating on that too much, and therefore you will not be able to elicit the response in the same way that you want. So you need to distract them, and there are distraction techniques. So what we do is, in the context of lower extremities, we'll ask the patient to interlace their fingers like so, and just pull apart, and as soon as they engage pulling apart, you strike, so that they are distracted here, and you will get a more accurate reflection of the actual reflex. In the situation where you're assessing upper extremities, the distraction here that generally used is clenching the jaw. So clench your jaw, if you will, and as soon as they clench the jaw, you'll strike the tendon again to reflect as accurate a result as possible. And so when you then note that, you will note with reinforcement or without reinforcement. So reflexes in the upper extremity measured 2 out of 4 bilaterally, all present and equal, without reinforcement. And that generally is what we would write in the medical records. So there you have it. Deep tendon reflexes why we perform them, what it is exactly that we are assessing, it's the virtual levels that they all reflect, and how we grade them, how we denote this in the medical records, and what clonus is, and what we might need to consider in that setting and situation. Thank you for watching.